I'm quite impressed with your discussion on the gait parameters. Do you actually use a XenoMat or some kinematic gait analysis software or map to analyze the gait characteristics so that you're able to really know what's wrong with our gait or whether the gait is just because of their age and orthopedic issues?
Yeah, so there's different therapies that I used to use. There used to be a gait lab I used to work with very closely, and unfortunately with COVID, they've had to close down. So there are certain gait labs that exist that are focused on such details of sway, positional, postural. A lot of our physical therapists utilize certain machines as well, and they give analysis based on timing, based on pressure maps of the feet. I get some clues and tips from that. I usually depend on the physical therapist to work on those details. And right now with practice, we haven't been able to utilize as much of those gait analysis, but it is quite helpful, especially when we start a medicine, or even, as you know, Dr. Evidente, with deep brain stimulation, how that may affect balance. In case we're worsening balance, we want to know what programs or stimulation parameters help.
And with patients that have undergone DBS, are you impressed with any differences between STM versus GPI for balance or freezing of gait?
Both can be beneficial based on certain situations. So I was trained at UCLA, which is a very big center on DBS, but they were very pro GPI, globus pallidus, which is an area for our audience that is much more away from the midline centers, away from the spinal canal and signals, whereas the subthalamic nucleus is a lot closer and medial of a structure. So if there was sometimes signals that are to the globus pallidus that we send, there's less potential side effects with over-signaling and overstimulation, whereas with the subthalamic nucleus, maybe we would get too much stimulation to help control a tremor that maybe we would affect parameters of speech or balance. Now, the key thing is if someone's very stiff or rigid, deep brain stimulation does a wonderful job, whether it's STN or GPI, to reduce that stiffness. And we can actually program in certain ways where speed can be improved. And so there are some times where we overstimulate one side, maybe like the right brain, to control the left foot very carefully by signaling it much more. And how we signal it, maybe a certain amount of voltage with a very low frequency. And there's other parameters, as we know, to maybe lower the pulse width, which is, again, a certain type of signal that's not too intrusive.
Okay, we have some questions from the audience. The first question is, I am surprised to hear only 35% number for gait survey. And was the morbidity increase only due to secondary events?
Yeah, and again, these are data that was done by, I think, the American Academy of Family Practitioners, but the mortality rates are, again, usually secondary measures, again, from the complications of fall that included bleeds, surgical complications, but again, related to hospitalizations from Parkinson's phenomenon.
And then a follow-up question to that is, please expand a bit more on CSF tests and what measures.
Yeah, so we do MRIs to look at the structures of the brain, but also there's certain cavities that we see called the ventricles of the brain. And those ventricles, certain areas can be actually enlarged. And as they enlarge, they put pressure on the white matter of the brain as well as the gray matter, and it pushes the brain centers really against each other. So if we think about a room that we're in and we're blowing up a balloon and blowing it up and blowing it up and blowing it up, it will cause space surrounding to be pushed against the walls. So same thing goes with the ventricles. If they're enlarged, it can cause some irritation to the brain centers for walking and balance and even thinking. And there's a mimicker of Parkinson's called normal pressure hydrocephalus, which again will affect balance, thinking, and even urinary control. So Sometimes we do what's called a lumbar puncture to measure the pressure of the cerebrospinal fluid. And if it's elevated, it may be suggestive a cause of normal pressure hydrocephalus to a certain degree, even though we say normal pressure, which should come out, but we see patients sometimes walk better right after taking out extra cerebrospinal fluid, and they may require something called a VP shunt if that's the case.
Yeah, and I'm quite impressed over the 2 decades I've been in practice, or probably more, of the coexistence of both Parkinson's disease and NPH. And in fact, I've counted maybe at least a dozen cases in my practice now. And so whenever I see patients with prominent lower body Parkinsonism, they're wide-based, they have gait ataxia, their feet are not together, they're not really shuffling, they're more ataxic more than anything else. Mm-hmm. And if imbalance is a very prominent issue from the get-go, and that's when I kind of suspect, especially as you mentioned, they start having some urinary urgency, and then later on incontinence, and even later on some cognitive issues. That's when I start suspecting that maybe NPH might be in play. I also suspect NPH when a patient is referred to me for Parkinson's, as mainly lower body Parkinsonism, no tremors, put on levodopa, and absolutely no response to levodopa, and their main concern is balance and falls. So I guess my follow-up question to you is, how frequently do you ask for brain MRIs in your patients that are referred to you for Parkinson's?
I would probably say that we also do CT scans as well, and if there's been specific concerns of newly diagnosed Parkinson's or something like normal pressure hydrocephalus, I typically would go to some more detailed MRI. Predominance is most patients would have some imaging already done. If not, I would like to at least get some baseline imaging. I would like to make sure that even if they have Parkinson's that looks like it's idiopathic, coming about as a slow progressive disease, as a majority case area, I want to make sure there's no mimickers of Parkinson's, like a stroke, a bleed. We see these situations where, in very rare situations, but they do occur, and we don't want to miss something that could be maybe treated, or it gives us an idea as to understanding why medicines are working or not working. I don't typically get a DAT scan necessarily, but I do focus on getting some form of imaging at least once at the beginning of a diagnosis. And then if there's major changes in walking or balance or numerous falls, I want to make sure there's not a bleed that has curtailed or occurred.
Yeah. Okay. Another question from the audience. What do you mean about blood pressure can fluctuate with Parkinson's? Can that be controlled, or is that the new normal?
Oh, wow. I mean, I'm sure most movement disorder specialists are now, they should get a second degree in being a cardiologist, because we focus so much on blood pressure. In Parkinson's, we see such erratic highs and lows. I mean, a patient could be sitting and I can check the blood pressure, and it can go it can be 110/70, and it can shoot up to 170/60 without, much time being passed, and they're just still sitting there. I've had patients who are sitting down and they're 160/40, and then they stand up and it drops to 70/30. There's such erratic drops of blood pressure and also erratic highs of blood pressure, and there's some system that's not working that is checks and balances to the highs and lows of these erratic blood pressure. So we as neurologists utilize some medicines to make sure the blood pressures don't drop too much. We have therapies that are there to keep blood pressure at a certain level, and we have to be cautious that the blood pressures don't go too high. But most of the time we reduce some patients' blood pressure pills that they're already on that controls their hypertension, so we can try to avoid the bottoming out.
Yeah, and there have been studies that have shown that even in the so-called pre-motor stage of Parkinson's, for synucleinopathies like Parkinson's disease or multiple system atrophy or dementia with Lewy bodies, that if you were to do formal autonomic testing, many of these patients actually have some autonomic abnormalities and orthostatic hypotension, which is what you just described very eloquently, which is a drop in blood pressure from lying to standing. And the cutoff usually is about 20 millimeters mercury of systolic blood pressure. Many of our patients actually, even in the early stages of a Parkinson's syndrome, or even the premotor stage, may have some form of autonomic neuropathy. It can predispose them to these orthostatic symptoms. But again, I think many patients also are asymptomatic. Like, I'm really impressed at how many of my patients with high blood pressure, with Parkinson's, and then we take their orthostatic blood pressures here. We're not sure whether it's a blood pressure pill that's doing that or the underlying autonomic neuropathy. They have 30 or 40 point drops in their blood pressures, and yet they're not dizzy at all. Yeah. So I guess a follow-up question to you is, do you treat automatically these drops in blood pressure, or do you wait till they're symptomatic, or what do you do?
Yeah, that's a very good question. So again, I'm talking to Foundation of Arizona. So you guys, as well as California, we deal with droughts, right? We deal with heat waves. So one of the biggest drops and causes for low blood pressure or autonomics is lack of hydration or dehydration, and that's something that if we're seeing drops of more than 10 millimeters mercury with the systolic top blood pressure, I definitely even start educating about how to be either liberal with salt, maybe adjusting medications. Even if they're asymptomatic, I always want to make sure I'm asking about, are you feeling dizzy, or asking about this unsteadiness. Sometimes patients may bring it out once you kind of really are asking such situations of like, when you bend over to pick up something, and when you get up, do you feel kind of woozy? Like in those circumstances, I will just be mindful of not necessarily with medicines, but just good habits. I typically would only start treating if they're becoming more symptomatic, or if I'm seeing that there are falls unexplained, then we typically go after that if there's objective measures.
Oh, yeah, absolutely. I echo that 100%. And especially here in Arizona, where we have dry heat, and many patients actually get dehydrated. They think they're drinking enough fluids when in fact they're actually perspiring all the fluids away, and therefore they get dehydrated despite taking the so-called recommended amounts of fluid. So I guess the first aid measure, or the first thing I ask them first, is how much fluids do you drink, and also I try to make them add some salt if the fluid hydration is not sufficient. Now, what about B12 deficiency? You mentioned in your talk the importance of the relationship of B12 deficiency and gait abnormalities. Do you feel like this is something we should be measuring routinely in our Parkinson's patients?
Yeah, one of the things that we learned is in training, as in neurology training specifically, was a test where you have a patient stand, and we call it the Rombergs for those who aren't aware of it, but it's you stand and then you close your eyes and then you see if there's an imbalance. That's one of the tests that if someone is unsteady significantly when they close their eyes, then I will definitely look for a B12 deficiency, and that's one of the hallmarks of it. If someone tells me, when I ask on the exam their social history, if they have any special diets and they say they're vegetarian, I typically would check for B12 deficiency. And anyone who comes in with a consultation that says, hey, I'm having balance issues, I will check for B12 and other types of associated minerals like homocysteine and methylmalonic acid. And there's certain tests that we would do to look for that. But I wouldn't say I would do it every single patient. But one thing is that we do see, even like vitamin D. Vitamin D is kind of, there's a lot of vitamin D deficiency out there. And I see that much more in the general population and even our Parkinson's patients, but that may not affect balance as much as something like B12 Actually, today of all days in the morning, I found someone who had a B12 that was extremely low, and her main complaint was memory issues and balance. So can't wait to see how she responds with high dosing B12. Typically, you know, we could do injections or ask them to take sublingual supplements, but you know, that is something that is quite important in addressing.
Yeah, a couple of important points that you mentioned that resonate to me pretty loudly. The first is you mentioned methylmalonic acid and homocysteine. So I think the take-home message is that a normalish or low normal B12 can actually not be normal, and that one of the things that Dr. Thakkar mentioned is taking the methylmalonic acid and homocysteine levels, which increase when you're not absorbing the B12 and the B12 is not making it to your tissue. So if we really strongly suspect, especially if you have a neuropathy, you're falling, you have imbalance, you have numbness of your feet, and so on and so forth, you have some cognitive issues, then despite the so-called normal B12, I usually push for the methylmalonic acid and homocysteine levels to be measured, and homocysteine is you know, elevated homocysteine levels have also been noted very frequently in Parkinson's patients without any B12 deficiency, because the metabolism of levodopa to dopamine depletes B12, and so. Or should I say, leads to increased homocysteine, rather, leads to increased homocysteine levels. So one way to bring down that homocysteine is to give these patients B complex, including B6, B12, folic acid. And then another question from our audience: can you have Parkinson's and begin to exhibit some of the early signs and symptoms without a positive DAT scan? What do you think, Dr. Thakkar?
Sorry, the positive DAT scan, without a positive DAT scan and early symptoms.
You have Parkinson's disease.
Yes, yeah. I mean, look, I typically go with my clinical assessment much more than the DAT scan. If the DAT scan is positive, then it's 99%. Yes, it's a Parkinsonism. But if it says negative, it could be incorrect 12% of the time, maybe a little bit less than that at time. But there's data that says it can be as incorrect with what we call a false negative for Parkinson's. And you know, if the clinical suggestion is there with tremor, stiffness, slowness in a certain pattern, you know, it doesn't mean that you have to right away treat, but you may follow up a patient for, again, after a month or two, and just kind of see how they're progressing and see if their symptoms are still very similar to what you first saw. And, you know, you really want to trust what you've been trained on. And like Dr. Evidente, you know, you've had so many years of seeing a patient, you know, you look at these other cues that not just a scan. We look at, is there history of constipation? Is there sleep disturbances that are talking, yelling, or acting out dreams? Are there circumstances of reduced sense of smell, and even loss of smell, less likely than less of taste, and then so again, constipation, we talked about, loss of smell, the REM sleep disturbances, and I also look for like muscle cramps. Muscle cramps are one of those Charlie horses, are one of those pre-phenomena that I see a lot as well with Parkinson's. So I really trust my skill set of that. However, we've had some unique ability to either give a patient a medicine of levodopa, whether we crush it right then and there in the office. And I've actually used Dr. Evidente Inbrija, which is an inhaled form of levodopa, to get an assessment of, does the patient respond, whether it's with handwriting or fine dexterity or tremors, does that go away within 15 or 20 minutes after, you know, while they're sitting in my office? And that kind of also gives me a clue more so than just worrying about a scan.
Yeah, very well said. I just want to add that I like Dr. Thakkar, I've seen patients that I really strongly suspect have idiopathic Parkinson's disease that's levodopa responsive. He just alluded to using the inhalational form of levodopa to test a levodopa response. Although with the caveat that it's the duration of response, the enduring response of levodopa is a stronger predictor of Parkinson's disease than the immediate, one dose or testing levodopa for a few weeks. So the pathology studies, especially the more recent ones, have shown that even among patients that are levodopa responsive, in a movement disorder center, for instance, where Parkinson's disease is very frequently diagnosed, supposedly by very experienced specialists, movement disorder specialists and neurologists that see Parkinson's every day, the rate of misdiagnosis can be as much as 42%, and sometimes even larger within the first 5 years. So really the enduring response to levodopa, and they throw out a random number of about 5 years. So enduring response of the levodopa of about 5 years with motor fluctuations, meaning on and offs, which usually develop anyway on an average 4 or 5 years from the start of levodopa treatment, as well as the so-called dyskinesias. So the enduring response, motor fluctuation, dyskinesias, most likely in a Parkinsonian patient will most likely represent Parkinson's. But I've also seen patients with DAT scans that have been misread, especially those that have asymmetric findings, or very subtle findings. Not every DAT scan is the same, or should I say not every DAT scanner is the same. There are some DAT scanners that are better than others. Also, there is a special software called NeuroQuant. So you can interpret DAT scans two ways. One is qualitatively and just looking at the images and saying, okay, the dopamine signal seems to be equal in both sides of the basal ganglia, or is it reduced in one side? Is it reduced in the caudate or the putamen, or both, and so on and so forth? That's qualitative. And then the quantitative, through a special software called NeuroQuant, actually measures the amount of dopamine signal in comparison to normal individuals. So I trust more the DAT scans with NeuroQuant data. But even so, the so-called normal DAT scans, if I really suspect that they truly have Parkinson's, and especially if I do a levodopa challenge, as you mentioned, I read the DAT scans myself, and I kind of say, okay, there's some asymmetry here. I think it's mildly reduced. And so I follow this patient like as if they have Parkinson's disease. And then they've also looked at these patients, they've taken a second look or even third look at these patients that initially had normal DAT scans. So there was a study, or even more than one study that's been published, where they took a second look at these patients, doing another DAT scan, maybe 1 or 2 or more years after. And true enough, a good percentage of these patients that were initially thought to be normal, but were thought to be clinically compatible with Parkinson's, converted to abnormal DAT scans. So the lesson is, if your doctor really feels that you have Parkinson's, you act like a duck, you walk like a duck, you quack like a duck, it must be a duck, regardless of whether the DAT scan is abnormal or not. Okay, some more questions here. I'm going to skip the question of REM behavior disorder, since I'm going to tackle that in the questions that were asked by the audience in the second part. Here's a question. Is there any relationship between essential tremor and foot neuropathy?
With essential tremor and foot neuropathy?
Are you aware of any?
I mean, there's different types of when I see certain dystonias, I actually see more neuropathy than essential tremor per se. But if there's a good amount of Parkinson's related tremor, then I would see more neuropathy as well, but not necessarily. I don't see specifically an essential tremor relationship typically with neuropathy.
I agree. Now there's a type of tremor called neuropathic tremor. So patients with bad neuropathy, CIDP, for instance, or one of these bad motor neuropathies with atrophy of muscles. Some of these patients can develop so-called neuropathic tremor, which looks like a crossbreed between essential tremor and a cerebellar tremor. Now, neuropathy can also occur in Parkinson's patients, obviously. And I think studies have shown that the chronic intake of levodopa can actually predispose to neuropathy. And this goes back to what Dr. Thakkar eloquently said in his talk about B12 deficiency, but they've also looked at folic acid deficiency in this population of patients, also B6 deficiency. Mm-hmm. Okay. Levodopa, how much can be used safely and what causes it to be ineffective? What is the next step after levodopa?
Well, you know, the dosing is not necessarily what we can hang our hat on. Some people can barely tolerate half tablets 3 times a day, and some people require over 2,000 milligrams a day. So, you know, each person is very individualized based on their response on blood pressure, if they can tolerate it as far as nausea. But, you know, what I've seen, and with more continuous like therapy of levodopa, I see a better smoothness of their physical symptoms, including walking. And I've seen some freezing of gait improve in such select patients. Again, anecdotally, this is under, again, in my clinic, we have a lot of patients who've done something called the Duopa pump, and it's a continuous levodopa, which has allowed for a better stream of flow. And some people do better with less festination and less short steps. They're more on. So whatever we do as neurologists, we want to optimize the on time. We want to have patients get a good response with levodopa, but maybe some patients get a good on with also some dopamine agonists, some boosters to levodopa that are medicines called MAOB inhibitors or COMT inhibitors. So there are medicines that sustain or lengthen the effectiveness of levodopa. And there are also maybe medications that cognitively slow you down. I mean, some patients take a lot of sleep medications, and we try to avoid medicines that are downers or muscle relaxants that slow our brain down. So there are medicines that actually make us have less on time because they are negative to our alertness and focus. So again, those are type of things that we must look at, not just a quantitative number of levodopa. We look at what other medicines patients are taking. But I've seen, you know, even in situations where, you know, historically people have said deep brain stimulation doesn't help gait, but there are times actually it can be quite useful. And again, it's more about what aspects of gait are affected, which is, again, if the stiffness is slowing down someone's balance, and like say the right leg doesn't just take good steps, you know, you can with DBS reduce some of that tension and muscle tightness that allows a patient to have more free steppage. So again, that's one of the perspectives I have seen.
Yeah, and I echo that as well. And I think you do this routine yourself. We do on-off testing before DBS, give them the maximum doses of medicines that they take, or if I feel that they're underdosed, I give them a heftier dose in my office, a levodopa challenge, and then see whether their balance or gait will improve. Whereas you know, literature will say that DBS is not meant to improve gait or balance. The truth of the matter is, any motor off symptom that improves in the on state, it is only present in the off state, will most likely improve with DBS. So for instance, I've seen patients with imbalance only in the off state, and that improves with DBS. Or for instance, I've seen patients with freezing of gait only in the off state. The moment they're fully on with their levodopa, the freezing completely disappears. And those are the patients that do very well with DBS.